Atherosclerosis is dangerous because it causes a slow progressive buildup of fatty plaque, which hardens and narrows arteries. This restricts vital blood flow to organs. It is the primary cause of heart attacks, strokes, and cardiovascular disease. If plaque ruptures, it can form blood clots that completely block arteries, leading to sudden, life-threatening events. Atherosclerosis happens when fatty deposits called plaque collect inside the arteries. As this material builds up, the space for blood to pass through becomes smaller. The plaque is a mix of cholesterol, immune cells, calcium, and tough fibrous tissue. It does not form in a single day. It develops slowly over 10 to 20 years. Many people only learn they have plaque after a heart attack or a stroke. That is why learning how food choices and daily habits can slow down and shrink plaque is so important. The real goal is more healthy years, better energy, and more time with the people you love. Atherosclerosis is not simply a normal part of aging. It is a long-term disease process shaped by genetics, environment, and everyday decisions. High blood pressure, smoking, diabetes, fatty liver, and high apolipoprotein B or ApoB cholesterol play major roles. Arteries deliver oxygen-rich blood to the heart, brain, and other organs. When plaque collects, it is like debris inside a drinking straw. As the opening narrows, the heart must pump harder to move blood forward. If a plaque tears open suddenly, like a blister breaking, a clot can form. That clot can block the artery and trigger a heart attack or stroke. Doctors use several methods to estimate plaque. A coronary artery calcium score, often called a CAC score, uses a CT scan to detect calcium in the heart arteries. In people over age 40, a score of 0 usually means low short-term risk. But this test only detects hardened, calcified plaque. It does not see softer plaque that may be more dangerous. Another test, carotid intima media thickness, or IMT, uses ultrasound to measure the thickness of the artery wall in the neck. It can pick up early changes before calcium appears. But it is used more often in research than in everyday clinical care. A CT angiogram, or CTA, can show both soft and calcified plaque and how much narrowing is present. Modern artificial intelligence tools can provide very detailed plaque analysis. An older invasive method, quantitative coronary angiography, or QCA, uses a catheter and dye to measure the inside opening of the artery. It shows the inner channel, but not the full plaque hidden within the wall. It is mainly used when doctors are considering placing a stent. To understand whether diet can truly change plaque, 6 major randomized controlled trials are often discussed. Studies are strong forms of research because participants are randomly assigned to different diet or lifestyle plans, and there is a comparison group. Case reports without a control group can be interesting. But, without comparison, it is hard to know how much improvement comes from diet alone. The 6 key trials include the Lifestyle Heart Trial, led by Dr. Dean Ornish, the STARS Trial, the SCRIP Trial, 2 Mediterranean diet trials called Pre-Dimed and CardioPrev, and a modern CT-based study named DISCO-CT. Together, they suggest that diet and lifestyle can slow plaque growth, stabilize it, and sometimes cause modest regression. The strongest results often appear when healthy habits are combined with medication and when people follow the program closely. The Lifestyle Heart Trial began in 1990. It included people with moderate to severe coronary artery disease. Each participant had at least one artery narrowed by 50% or more, and evidence of reduced blood flow. Out of 48 participants, 35 completed the study. Lifestyle Group followed an intensive program. They ate a whole food vegetarian diet with less than 10% of calories from fat. They limited simple sugars. They focused on fruits, vegetables, whole grains, and legumes. They walked or did moderate exercise daily. They practiced stress reduction with yoga and meditation. They attended weekly support meetings. They did not smoke. The control group received usual medical advice but no structured program. In this study, cholesterol-lowering drugs such as statins were not allowed in either group. Today, that would not be considered ethical for people with serious heart disease. But at that time, it allowed researchers to isolate the effect of lifestyle. After 1 year, the lifestyle group showed a 2.8% average improvement in artery narrowing, which was a 6.7% relative improvement. The control group worsened by 3.9%. LDL cholesterol fell by about 40% in the lifestyle group, compared with only 1.2% in the control group. The measurement method, QCA, assessed the artery opening rather than total plaque volume. But the improved artery diameter, large LDL drop, and fewer heart events strongly suggest plaque burden decreased. After 5 years, the difference grew larger. The lifestyle group improved by 9.7% on average. The control group worsened by 27.5%. Those who followed the program most closely improved by about 17%. Around 60% of the control group later started lipid-lowering medication. Even so, their arteries worsened more than those in the lifestyle group. This suggests intensive lifestyle change alone outperformed usual care at that time. It also raises the possibility that combining lifestyle with modern medication might produce even better outcomes. Heart events told an important story. In the control group, 20 people experienced 45 heart-related events. In the lifestyle group, 28 people had 25 events. That means fewer events per person in the lifestyle group. But the program included diet, exercise, stress management, and social support. It is not possible to separate which part contributed most. The STARS trial in 1992 studied 90 men with heart disease and high cholesterol, around 280 milligrams per deciliter. They were divided into 3 groups. One group followed a cholesterol-lowering diet low in fat and cholesterol, with more fruits, vegetables, grains, and fish, and less red meat, eggs, and full-fat dairy. The second group followed the same diet, plus took cholestyramine, an older cholesterol-lowering drug. The third group received usual care. After about 3 years, total cholesterol remained high at about 268 milligrams per deciliter in the usual care group. It fell to about 238 in the diet-only group. It dropped further to about 215 in the diet plus drug group. Plaque progression occurred in 46% of the usual care group, while only 4% showed regression. In the diet-only group, 15% progressed and 38% regressed. In the diet plus drug group, 12% progressed and 33% regressed. Artery narrowing worsened in usual care, stayed roughly stable with diet alone, and widened modestly with diet plus medication. Both intervention groups had fewer heart events. But the study included only men and used an older medication. The SCRIPT trial in 1994 enrolled about 300 adults with confirmed coronary disease. Participants were assigned either to intensive lifestyle management or standard care. The lifestyle plan included a low-fat, low-cholesterol diet, exercise guidance, weight management, smoking cessation, and cholesterol-lowering drugs when appropriate. After 4 years, the rate of artery narrowing in the lifestyle group was 47% lower than in the standard care group. LDL and APOB levels improved. HDL increased. Triglycerides fell. Weight and exercise capacity improved. There were 25 hospital admissions for heart problems in the lifestyle group, compared with 44 in standard care, nearly a 40% reduction. Death rates were low and similar in both groups. The pre-dimed trial in Spain enrolled more than 7,000 adults aged 55 to 80 who were at high cardiovascular risk but had no diagnosed heart disease. About 57% were women. Participants had type 2 diabetes, or multiple risk factors. They were randomly assigned to a Mediterranean diet with extra virgin olive oil, a Mediterranean diet with mixed nuts, or advice to follow a low-fat diet. The Mediterranean groups consumed more olive oil, nuts, fruits, vegetables, legumes, and whole grains, with moderate fish and poultry and less red meat and sweets. After a median follow-up of just under 5 years, the trial stopped early due to clear benefit. There were 288 major cardiovascular events overall. The olive oil group had 96 events, about 3.8%. The nut group had 83 events, about 3.4%. The control group had 109 events, around 4.4%. Both Mediterranean groups showed about a 30% lower risk of major events compared with control. Those who adhered closely to the diet had up to a 58% lower risk. A smaller imaging sub-study found that the control group's artery thickness progressed. The Mediterranean plus nuts group showed regression in artery wall thickness. The olive oil group remained stable. There was no clear difference between the two Mediterranean groups. The CardioPrev trial in 2022 studied people with established heart disease receiving modern medical care. It compared a Mediterranean diet with a low-fat diet. Over time, the Mediterranean pattern showed advantages in reducing further heart events and improving risk markers. The DISCO-CT study in 2020 used advanced coronary CT scans and artificial intelligence to measure plaque volume and type. It showed that intensive treatment, including diet and medication, could reduce high-risk soft plaque and improve overall plaque stability. This highlights the importance of plaque quality, not just quantity. Taken together, these trials show several key lessons. Diet can meaningfully affect atherosclerosis, especially when followed consistently. Intensive plant-focused diets combined with lifestyle changes can lead to measurable improvements. Balanced diets combined with medication can slow progression and sometimes widen arteries slightly. Mediterranean eating patterns rich in olive oil, nuts, fruits, vegetables, legumes, and whole grains lower major event risk by around 30% in high-risk individuals. Medication remains important, but healthy habits make medications more effective. Adherence is critical. The people who followed dietary advice most closely experienced the largest reductions in risk, sometimes up to 58%. Modern imaging confirms that combined strategies can shrink higher-risk plaque and stabilize the rest. In daily life, this means you can influence your artery health. Emphasize whole plant foods, fiber-rich meals, quality fats from olive oil and nuts, and limit refined carbohydrates, processed meat, red meat, and saturated fat. Stay active. Manage stress. Do not smoke. Take prescribed medicines as directed. The goal is steady progress, not perfection. Small, consistent choices over many years can keep arteries more stable. If you have risk factors or a strong family history, speak with your doctor about tools such as KIAC scoring or CT angiography to understand your personal risk. If you found this helpful, please click the like button and subscribe to the channel. Your support helps me continue creating educational content. Thanks for watching. I look forward to seeing you in the next video.